Good evening, everyone. Am I audible? Yeah. Believers Church Medical College Hospital is inviting you all for the 88th international webinar. We are happy to be associating with the Association of Clinical Biochemists of India today. The moderator for today is Dr. Professor Kannan Vaidyanathan sir. Sir did his MBBS from Government Medical College Kottayam and his MD from Government Medical College Trivandrum. He did his postdoctoral fellowship in microbiology and cell biology from Indian Institute of Science. He has worked in Cooperative Medical College Kochi, Amrita Institute of Medical Sciences, and Pushpagiri Institute of Medical Science. Currently, Sir is working as a professor and head in Believers Church Medical College Hospital. He is also a member of the Board of Studies of the Kerala University of Health Sciences. Sir is a task force member for newborn screening in International Federation of Clinical Chemistry and Laboratory Science. Over to you, Kannan, sir.
Thank you, Dr. Prakash, for your kind introduction. So thank you all for joining today. We are having more people joining in, and let's not delay much, and let us start today's session. The topic for today is very interesting: cardiovascular medicine and laboratory medicine. So as you all know, the laboratory medicine plays a major role in cardiac biomarkers. Lots of cardiac biomarkers are coming up, and there are lots of new developments coming up with the IFCC also. Some of you might be aware that has amended some of the regulations or recommendations regarding some of the cardiac biomarkers. Let us hear from the speakers what they had to speak about today's topic. And each speaker has 20 minutes, including discussion. So I'll be looking at the questions and I'll be sharing with the speakers. We have 3 speakers for today. I'll be each speaker before they start their talk. But first, we have Dr. Su Wei. She's from Singapore. And Dr. Su Wei received her PhD in 2007 from the University of Singapore, National University of Singapore, from the Department of Physiology. And subsequently, she spent 7 years working in the Mayo Clinic as a research fellow. And she has worked on a lot on various aspects, and she has worked as a research scientist in oncology with very senior scientists, Kyowa Hako Kirun. And she was a part of the medical affairs at Takeda Pharmaceuticals, and currently she's working as a scientific marketing manager for Beckman Coulter Diagnostic in high growth market. So over to you, Dr. Su Wei, and let us hear from you what you had to speak on your topic.
Thank you very much, Dr. Kannan, for the kind introduction. Can I just confirm that you can hear me?
I can hear you. I can hear you.
All right, thank you. And can you see my screen, my slideshow?
Yes, we can.
Okay. So the topic of my presentation today will be on biomarkers for cardiac diseases and diagnostics. But given our challenging time frame of 20 minutes, we have picked 2 biomarkers to discuss today, which would be troponin, namely high sensitive troponin I, as well as denaturate peptides. And we'll talk about BMP and NT-proBNP from the natriuretic peptide family. So the first part of this presentation will focus on how we can deliver better patient care with high sensitivity troponin I. So as you may know, we've had many iterations of the troponin assay over the past 10 years. And the most recent and up-to-date version of the troponin assay is what is known as high sensitivity troponin. So why do we need such a sensitive troponin assay? One of the key reasons is because this can help to diagnose acute myocardial infarction in women more effectively. women have, if you look at this graph on the right, you can see that over time, from 1979 all the way to 2001, women's mortality trends in cardiovascular disease are not declining in line with the men's. And this is because there are differences in the reference range between men and women. So using earlier version of a less sensitive troponin assay with single diagnostic thresholds, meaning just one cutoff point, may lead to underdiagnosis of myocardial infarction. And again, I'll talk a little bit about how we should be using troponin assays to and their cutoffs to diagnose myocardial infarction. But using a high sensitive troponin I assay with gender specific diagnostic thresholds can help to double the diagnosis of myocardial infarction in women and improve overall patient care. So the IFCC has come up with some fairly recent guidelines to define what exactly is a high sensitivity troponin assay. And there are two key features here that the assay must have. It has to have a coefficient of variation of less than or equal to 10% at the 99th percentile of the reference population. And must have at least 50% measurable concentrations that are below the 99th percentile. So it must be able to measure at least 50% of a healthy population and above the assay's limit of detection. And most of the troponin assays today are able to measure at least 50% or more of a healthy population. In addition, it should be able to measure 50% of healthy individuals above the limit of detection in men and women separately, because as we know, women do have a lower reference interval as compared to men. And I want to quickly jump to some of our early adopters of the Beckman-Coulter Access High Sense Troponin I assay. And what are we actually most interested in? To be honest, we are most interested in health outcomes, patient outcomes, not so much about the specs, right? And I really like this paper from this group in Australia that adopted our high sense troponin I assay about, I think, 2 years ago now. And you can see that pre-implementation of the assay, this is the hospital length of stay. And you can see that overall, after post-implementation, this stingray diagram actually widens out at the bottom. So this overall indicates that there is a reduction in the length of stay. And if you were to look at the data, the authors actually state that there was a reduction of length in stay by 2 hours. And it doesn't seem like a lot, but they did some health economic modeling, and this resulted in a saving of Australian dollars of about $15 million per annum, which is actually quite significant. So now that we know, we have some evidence that high sensitive troponin I does improve overall patient care. Let's look at the guidelines again, right? How do we diagnose myocardial infarction? So the fourth universal definition of myocardial infarction from the European Society of Cardiology says that myocardial infarction should be used when there is acute myocardial injury, meaning that troponin levels are at least one value above the 99% upper reference limit, and is considered acute if this troponin value is rising and or falling. But this is just myocardial injury. Myocardial infarction should be only considered when there is myocardial injury as defined here, together with clinical signs and symptoms of myocardial ischemia, or ischemic ECG changes, for example, or additional imaging evidence. So just going by a single elevated troponin value is no longer enough to diagnose a patient as having an acute myocardial infarction. The troponin value needs to be either rising or falling, and there has to be additional clinical or imaging evidence. And why is this so? This is because there are actually many other conditions that can result in a rise of troponin value. So if you see a patient coming in and maybe he has some pain, but as we know, pain in the chest could be due to anxiety, it could be due to reflux, asthma, not necessarily due to the fact that the patient is having acute myocardial infarction. And in fact, the guidelines do list other systemic conditions, right, that can cause similar pain-like symptoms, as well as an elevated troponin value. So for example, patients coming in with chronic kidney disease, sepsis, even patients with pulmonary embolism may also have elevated troponin value. So it is very important to combine that troponin value together with other clinical signs and symptoms or imaging data. And as we look at the troponin values, because the troponin acids are very sensitive now, they can be very effective for both early rule out as well as rule in. So let's look at the rule out data. And this is from the National Institute for Health and Care Excellence. These tests, including the Beckman-Coulter Access High Sensitivity Troponin Assay, is recommended for early rule out test strategies. And one of the test strategies, one of the examples of such strategies has also been published this is the same Australian group in New South Wales, and they looked at different types of protocols for ruling out acute myocardial infarction combined with a troponin value. So when you combine this together with troponin value, you can see that overall the sensitivity is actually very high, suggesting that there is a very good accuracy in ruling out acute myocardial infarction when you combine the troponin cutoff together with any of these accelerated diagnostic pathways. So coming back to the myocardial infarction guidelines, they did mention that the troponin values must be accompanied by a rise or fall of troponin values in order to be classified as acute myocardial infarction. So what exactly is this rise or fall of troponin values? If you were to look at the most recent ESC guidelines, this suggests they suggest to look at the delta or the change in troponin values between 0 to 1 hour and 0 to 2 hours. And you can see that the excess Beckman-Coulter assay, whether it's using the 0 to 1 hour or the 0 to 2 hour algorithm, has different cutoffs that you can use to classify the patients as low risk or what is considered as high risk if the patient comes in with a higher cutoffs at these values here. So again, the guidelines do recommend how to use troponin values if you were to use either the 0 and 1 serial change in troponin values or the 0 to 2 algorithms. And this is one example that was published in 2019 of the performance of excess high-sense troponin I. So what you can see here is that a patient comes in with chest pain onset of more than 3 hours before presentation to the emergency department. So one example of rule out is a patient comes in and he has a baseline of less than 4 nanograms per liter of high sensitive troponin I, you can rule out, and the sensitivity and the negative predictive value is 100%. Similarly, if a patient comes in with a troponin baseline value of 50 nanograms per liter or a change of more than or equals to 15 nanograms per liter, you can see that overall specificity is very high, between 97 to almost 99%. So taken in totality, you can see that they're using this particular algorithm to rule out patients. You get a very high negative predictive value and sensitivity of almost 100%. And even your positive predictive value for the rule-in is pretty high at 74%, and specificity is high at 96%. In terms of long-term patient outcomes, 30-day survival using the rule-out algorithm is 100%. And you can see that even with the rule-in, and these are patients, who do have, cardiac issues that are ongoing, you can see that the 2-year survival is still pretty good at almost 90%. So in addition to what was indicated by the ESC 2020 guidelines, we do have delta change values indicated in our instructions for use as well. So one example I like to highlight is that if patient comes in and there is a delta change of say 22 nanograms at baseline versus the second draw at 1 to 3 hours, the positive predictive value is also pretty high at 90%. So overall, just to quickly sum up this section on high sensitive troponin I as a biomarker, you can see that we have very good rule out protocols at 0 and 2 hours, regardless of which diagnostic protocol you want to use. If you were to use the 0 to 1 hour algorithm, like the example I showed you, there was good diagnostic accuracy with high safety and the rule out zone of almost 100% looking at negative predictive value. And even for positive predictive value for rule in, it was 74%. So overall, using the 0 to 1 hour algorithm, when a patient comes in with chest pain or onset of chest pain for more than 3 hours, almost 3/4 of patients could be assigned to either rule out or rule in within 1 hour, which is very important for managing the patient load in a busy emergency department. And I think furthermore, workflow consolidation of critical care biomarkers like troponin can improve total turnaround time in terms of delivery of results from the laboratory as well as patient care. So with that, I will kind of change gears a little bit and talk about natriuretic peptide testing. So today, I would also like to touch a bit on BMP or B-natriuretic peptide testing in heart failure. So we've talked about myocardial infarction. And I also want to emphasize that heart failure is not myocardial infarction. It's actually two very separate conditions. We discussed how myocardial infarction is an acute event of a lack of blood flow, whereas heart failure is a chronic and progressive condition in which the heart cannot pump enough blood to meet the body's needs. And what exactly is BMP or B-natriuretic peptide? It's actually called brain natriuretic peptide. It's produced primarily in the left ventricle of the heart. And a small amount of a precursor protein called proBNP is continually produced by the heart, and it's also then cleaved into what we know as BNP and NT-proBNP, which are the two biomarkers in the market today that are used to assess and manage heart failure. So overall, when the left ventricle weakens, there's blood remaining in the ventricle, and each contraction causes this weakened ventricle to stretch. And it is this stretching that actually causes the release of BNP and NT-proBNP, meaning that these are biomarkers indicative of a failure of a heart to pump blood effectively throughout the body, because there's residual blood in the ventricle with each contraction. So again, these are biomarkers that there is heart failure, there's ongoing heart failure in the patient. So this just indicates the synthesis of proBNP and how it can be cleaved into NT-proBNP and BNP at equimolar in an equimolar ratio. So what about the guidelines? What do they say about BNP and NT-proBNP? These are the two common biomarkers that are available on the market for assessing heart failure. And you can see that regardless of whether it's BNP or NT-proBNP, they are indicated equally, whether it's for prevention of heart failure, for diagnosis, or for prognosis. And of course, the green boxes have the highest evidence and support for both diagnosis and prognosis. But even for the yellow boxes, which have a lower level of evidence, you can see that both biomarkers are indicated for use equally. So just to maybe reiterate, BNP is a simple and objective measure of cardiac function, and it can be used to diagnose heart failure. Overall, BNP helps to promote diuresis, natriuresis, and vasodilation of the systemic and pulmonary vasculature. But again, BNP and NT-proBNP come from proBNP. They come from the same molecule, and they are released in an equimolar ratio. Is there really a difference? Are there a difference in these two molecules, and how do they track? So I think a few key things to note. These are two separate assays. So you may be using NT-proBNP in the lab, and you're thinking of maybe consolidating onto BNP because maybe you're running on a platform that you can consolidate BNP with, for example, troponin or other types of critical care biomarkers. One thing to note is that these two biomarkers, their absolute values and cutoffs are really not interchangeable. So they all have separate groups of values and cutoffs. Take note. BNP is a shorter half-life than NT-proBNP, and NT-proBNP has a stability of 6 days at 2 to 8 degrees Celsius, and BNP has stability of 24 hours at 2 to 8 degrees Celsius. But I think these days, these are critical care biomarkers, and you usually almost run immediately. So perhaps the sample stability issue is not so pertinent in this case. However, we want to also reiterate that both guidelines, whether it's US or European, recommend either BNP or NT-proBNP as an aid in the diagnosis of heart failure. So just to talk a little bit about the differences. So BNP's half-life is 20 minutes, and NT-proBNP's half-life is 1 to 2 hours, which means that NT-proBNP elevates sooner and it stays higher due to its slower clearance. And what this means is that BNP's 20-minute half-life can more closely reflect the patient's current condition, because, for example, if the patient presents to the emergency department at 6 a.m., a BNP value can represent the patient's condition maybe at about 1 hour ago, whereas the NT-proBNP probably represents their condition much earlier, maybe the night before, because it has a higher half-life, so it takes a longer time to clear. And in fact, why does NT-proBNP have a slightly longer half-life? This is because BNP is cleared 4 ways. That's why its half-life is only 20 minutes. And NT-proBNP is only cleared by the kidneys. So what this means is that if you have patients coming in, older patients, geriatric patients with kidney disease, the BNP results will not be adversely impacted. Whereas NT-proBNP only being cleared by the kidneys, if there are kidney problems with the patient, NT-proBNP values may remain high. So again, if you're the physician looking at the patient, you may ask, why did their BNP change? Is it due to worsening heart failure, or is it because due to worsening renal insufficiencies? These are some questions that you may have to wrestle with. So these are the indications for our Access BNP assay on our Kutzler platform of immunoassay analyzers. It is a quantitative test for aid in the diagnosis of congestive heart failure, for assessing of heart failure disease severity, and it can also be used for risk stratification of patients. In the interest of time, I won't go through all of these cutoffs, but suffice to say that we do see the standard cutoff that we usually use is 100 picograms per mil for patients without heart failure. So this is a quick and easy rule-in, and above 100 picograms per mil is abnormal. Okay, and every 100 picogram increase in BNP concentration, you do see a 35% increase in the relative risk of death. We also have cutoffs for, we've also looked at the 100 picograms per mil cutoff for various age groups, and we've looked at the sensitivity, and we've looked at it for males and females. And I think overall, for males, we do see fairly comparable sensitivities. For females, especially for the older patients, even just using that same one cutoff, the sensitivity is still pretty high. It dips a little bit here for the 45 to 54 age group, but I think if you're looking at a geriatric patient who's coming in with heart failure, rest assured that I think using this cutoff, you still have pretty high sensitivity for the older patient age group. So this is actually my last slide, and thank you for listening to me today. I just wanted to also highlight that the New York Heart Association developed a 4-stage classification system for heart failure. And looking at the different BMP concentrations, you are able to also risk stratify the degree of severity of heart failure in the patient as per the New York Heart Association classification system. So you can see that stage 1 is well below the 100 picograms per mil cutoff that I mentioned earlier. And then with increasing levels of BMP, you do see an increasing severity of heart failure. So I think with that, I would like to end my presentation today and pass it over to the moderator. Thank you for listening.
Thank you, Dr. Suve. Excellent presentation. I wish I could give you more time to explain the details. It was very short, I know, to explain.
Very challenging, but thank you.
You did a great job in
Thank you.
Thank you very much for that. Can we have any quick questions, a couple of questions which would anybody would like to ask Dr. Suve? I don't have anything on the chat box. Anybody having any doubts? Okay. Anybody raising the hands? Okay, you can stay online in case somebody has any doubts towards the end of the presentation. So thank you very much for your presentation. Thanks a lot. So the next speaker for today is a cardiologist, and I'm sure everybody is waiting to listen from him. Dr. Vimal Mehta is a senior cardiologist from the G.B. Pant Institute, Postgraduate Institute of Medical Science from Delhi. So Dr. Mehta did his MBBS from Delhi University College of Medical Science in Delhi, and after that MD and DM from Maulana Azad Medical College, and MD from that was in 2002 he completed his DM. He has lots of recognitions and lots of publications, and he has also been involved in many clinical trials. And just if I go on talking about him, I'll be spending a lot of time on that, but he has spent a lot of time of his clinical career on clinical trials, etc. So he is an excellent speaker for today, and I invite Dr. Vimal Mehta to share his presentation. Dr. Vimal, can you hear me?
Yeah. Thank you so much, sir, for the kind introduction. And I hope my slides are visible.
Yeah, it's visible, sir. You're audible as well.
Okay.
Yeah.
Okay. So I just move this thing a little over there. Yeah. So thank you, sir, for the kind introduction. The topic of my talk is biomarkers in lipid-associated risk and its management in atherosclerotic cardiovascular disease. And as sir said, that I've been involved in various multinational drug trials. I'm principal investigator of this site and lots of lipid publications. In fact, 15 days back, in this prestigious journal of National Lipid Association of America, we got this paper published on LDL-C lowering and acute coronary syndrome. Now, why this topic is important? Because cardiovascular disorders are responsible for 1/3 of death worldwide. Nothing great in that. As far as our country is concerned, what is concerning is that disease manifests at least 1 to 2 decades earlier compared to Western population. And infarctions occur in younger people much more commonly as compared to Western population. And why is so? There are multiple risk factors, the important ones being the high prevalence of dyslipidemia and high prevalence of diabetes, and which is a deadly combination. In fact, as this slide shows, since 1990, age-adjusted cardiovascular mortality has been rising in our country, both in men and women. And India study sponsored by ICMARCH showed that prevalence of dyslipidemia is as high as 80% in our population. And since last 4 decades, the incidence of diabetes is rising, and red color shows the states where prevalence is in adults is as high as 12% or more. And this results in atherosclerosis, and atherosclerosis is thickening and hardening of the arterial wall, mainly because of deposition of lipids, and on top of that there is inflammation. And initial lesion is fatty streak, which is seen in even younger children and young adults. However, it is reversible. However, if the process goes unabated, then we have a full-blown atheroma, and where there is lot of lipid and there is lot of inflammation, ultimately plaque rupture and further complications and increase in this atheroma size results in myocardial infarction. And we can do intravascular ultrasound and do lots of other things. Here you see the shown in green is the all is plaque atheroma, which is blocking the lumen, and once it goes, it increases in size and it causes symptoms. Now, biomarker is defined as any measurement made on a biological system. And this, what are the biomarkers for lipoprotein, for our lipid associated risk? And before that, we have to understand lipid, why if it is so problematic, why it is there. Lipid in a normal diet is responsible for about 25 to 30% of the calories in a day. And lipids are insoluble in water and in blood, so they are carried by these lipoproteins, which are nothing but carriers. So they contain the material to be carried, that is triglyceride and cholesterol inside, and outside is a hydrophilic wall which consists of phospholipids, some cholesterol, and apolipoprotein, which is the protein component of lipoprotein. It acts as a membrane stabilizer as well as a ligand for various receptors, as we will see later on. So these are the biomarkers: chylomicron, remnants, VLDL, IDL, etc. And they have apolipoprotein, which are specific to each lipoprotein, as shown over here, and I'll dwell upon it later on. Now, in a normal individual, what happens is that these lipoprotein particles, they are in blood, so they go inside the intima and come out, and this process goes on. However, if these levels are too high, that is, there is hyperlipidemia or there is lot of inflammation, then there is a problem. And these get accumulated inside the arterial wall. And as shown over here, they go into the arterial wall, and if this process goes unabated, there is oxidation of these LDL particles. They are taken up by macrophages and results in formation of foam cell and fatty streak, as shown earlier. And if this process is further exacerbated by vascular inflammation, by smoking, diabetes, hypertension, etc., and there is endothelial injury, such that space between endothelial cells is increased, and this attracts further mononuclear cells, macrophages, etc., T cells, and this inflammation and lipid combination is deadly. Now, it is important to know how these are formed. Hepatocyte, in the hepatocyte as well in the enterocyte, free fatty acids are esterified by diacylglycerol acetyltransferase to form triglycerides, and in the hepatocyte, Apob 100 is added. In enterocyte, Apob 48 is added to form VLDL by microsomal triglyceride transferase protein. And what happens is that this goes into the circulation, and in the capillaries, in the myocyte and adipocyte, for giving energy to the myocyte and adipocyte, and for storage in adipocyte, the triglyceride is extracted by the action of enzyme lipoprotein lipase, and such that it converts into intermediate density lipoprotein and VLDL remnants, and ultimately to LDL. So what is the difference? As the triglycerides are taken out by the action of LPL, the size decreases and the triglyceride content decreases, and ultimately we have a LDL particle which is 90% cholesterol, vis-a-vis VLDL, which has 80% triglycerides and only 20% cholesterol. Chylomicron and chylomicron are not much of a concern in general population unless one is genetic defect, because their half-life is only about 30 minutes. So they are not in circulation for a long time. vis-a-vis, for example, LDL is half-life of 3 to 4 days, 2 to 3 days. Now, it is important to note the size of these particles because anything less than 70 nanometer can penetrate the intima and can cause atherosclerosis. So we see VLDL, their remnant, intermediate dense cholesterol, LDL, and chylomicron remnant, they all are coming in the range of 70 to 80 nanometers or less. So they are all can be atherogenic. And we measure in biochemistry. See, clinician is blind without the help of biochemistry department because they will tell us what is the risk a given patient has by measuring total cholesterol, triglyceride, and HDL directly. And in general, LDL is calculated by this feedback formula: total cholesterol minus HDL minus triglyceride divided by 5. However, in certain circumstances, LDL can be measured directly by many methods, including beta centrifugation. So levels are less than 200 for cholesterol, less than 150 for triglyceride, and LDL 60 to 130 in normal population. And we know from innumerable studies, animal models and human studies, that as the levels of LDL rises and they remain increased over a period of time, they result in atherosclerotic cardiovascular disease. And there are various drugs have been developed, including statins, which are the most commonly used and most effective agents. They reduce LDL by about 50%. How they act is they decrease LDL cholesterol, decrease atheroma volume, and they also classify the vulnerable plaque and hence decrease the subclinical and clinical ischemia. They also have pleiotropic effects. And another biomarker is of importance of patients who are on statin, that is C-reactive protein, which they decrease by about 30 to 40%. And it has been shown that higher dose of atorvastatin is important vis-a-vis low dose of atorvastatin, and it decreases the events as shown in this 10,000 patient study. Now, despite giving the high dose of statin, there are still residual risks. That is, patients taking statin and still many of them still continue to have events. It has been shown that lower is the achieved LDL, that is LDL on drug, the higher is the benefit. And we initially, it was proposed that up to 125 till 2002, it was thought that LDL of 125 is okay. Reducing it further will not reduce risk. Now consider that day and today that from our association, Lipid Association of India, we have proposed and has published multiple papers in national international journals of repute that LDL goal of less than 50 is must in patients who are at high risk for future events, including those with established disease, and as low as less than 30 in patients who have additional risk factors like diabetes and who have multiple disease areas like patient has stroke as well as peripheral arterial disease as well as coronary artery disease, which are not uncommon. So these patients as low as 30 are recommended by our association and has been well accepted. And as I said, why this is necessary so low? Because at every levels of less than 70 as recommended by the American Heart Association, 2/3 of patients still continue to have events despite being on statins. And one of the reasons is that, you know, in various registries, only 20% patients have been able to achieve the goals recommended by various societies. And now we have other drugs, azithromycin, 18,000 patient study, modest reduction of 6% in event rates, predominantly because of reduction in MI and ischemic stroke. This drug basically decreases the absorption of cholesterol from diet, and more benefit was seen in the diabetic subgroup as shown by absolute reduction of 5.5%. Another important agent on which we have worked a lot, I personally have worked a lot, is PCSK9 monoclonal antibodies. In short, what they do is they increase the number of LDL receptors by 2 to 3 times on the hepatocyte surface, such that more LDL is caught and LDL levels are reduced from the circulation. This is study, multinational study, 4-year study in which we also participated, 27,000 patients. And this drug given over 2 years, as you show immediate effect this is at 4 weeks, there was 60% reduction in the LDL, such that around 20% patients achieved LDL of less than 20 milligram per deciliter, which was unachievable before this based on the drugs available. And this was an earlier publication, March 2020 publication, again in this official journal of National Lipid Association of America. So this is what we recommend: high intensity LDL in patients and optimal control of diabetes and hypertension. If LDL is still high, you add STMI, still high, then you add monoclonal antibodies. However, they are costly. And if we add all these three, then we can reduce LDL in today's era by as high as 80 to 85%. And now there are important areas. Now, from a biochemistry angle, from a clinical angle, we want to know patients are still suffering events. What more we can do? Are other lipoproteins responsible? The burning question is, do triglycerides also cause atherosclerosis? The answer is that triglycerides are not directly responsible, but the cholesterol content of the triglyceride lipoproteins, importantly VLDL particles, is atherogenic, as I will show you a little while later. Because triglycerides can be degraded by most cells, and in fact, it is the triglyceride which are ultimately degraded by the action of lipoprotein lipase in the arterioles, in the various systems in the body, so as to get free fatty acids for energy. It is the cholesterol content of the triglyceride lipoproteins that is the remnant cholesterol. It is called a remnant cholesterol, which is responsible for atherosclerosis and which is the one which gets deposited in the intima. Now, VLDL, as I said, 80% triglyceride and 20% cholesterol. Now, two things can happen to it. Over here, as you see, it can be hydrolyzed, as I saying again and again, and it results in VLDL remnant, which are lesser triglyceride, more cholesterol component, and which is atherogenic. Or in what happens in diabetic subjects is that there is lot of there is huge amount of triglyceride, that VLDL particles are bigger and have more triglyceride, and they give triglyceride to LDL in return for cholesterol ester by the enzyme called cholesterol ester transfer protein. And this triglyceride from here is taken by hydrolyzed or lipolyzed by lipoprotein lipase, and such that ultimately we have a smaller, denser LDL particle, which is much more atherogenic and is typically seen in diabetic patients. And in fact, it has been shown that once the triglyceride levels increase above 150 or so, the LDL particles are smaller and denser. Why this is important? Because being smaller, they are able to enter intima easily, get oxidized easily, get entrapped in the proteoglycans of the arterial wall easily, and are much more atherogenic than the larger buoyant LDL particles. So, and it has been shown in the Framingham study that hypertriglyceridemia associated with increased risk of CHD, and patients who have lesser LDL levels as well as less triglyceride levels, they are the ones who are at lowest risk vis-a-vis patients who have only LDL control. So control of both is important. We have drugs available, fibrates, niacin, and omega-3 fatty acids have come up in a big way, as I'll show you later. Now, question arises in everybody's mind that what do I do if a patient has triglyceride of 350 or so? We have a full algorithm, but in general, a triglyceride level up to 500 are associated with cardiovascular risk. However, levels more than 500 in general are associated with pancreatitis. And the important point is levels up to 500 are typically seen with diet and etc. However, levels above 500 most of times have a genetic component to it. And this is a complex algorithm. To cut a short story, long story short, statins are the drug of choice, even for hypertension, because they reduce triglycerides by as high as 35%. And after that, omega-3 fatty acids are added, which have been recently shown to decrease myocardial infarction as well as cardiovascular mortality. And as I said, it is the remnant cholesterol, that is the cholesterol component of the... Yes.
2 more minutes.
Okay. So it is the cholesterol component which is responsible. And there is no direct measurement for remnant cholesterol. It is a derived measure. So how we calculate it in a given person is by estimating triglycerides. Higher the triglycerides, higher the triglyceride lipoproteins, higher the remnant cholesterol. Now, Apob is important because each particle has one Apob. So what happens is, for example, this is the LDL particle, large buoyant particle, it has one Apob, and these are multiple small dense LDL particles which again have one Apob. So there will be 15-20 Apobs, and their mass is same. That is what, and what we measure is mass. So here comes the importance of Apob. You have a diabetic person whose LDL is around 90. You are very happy, but he has many more particles despite having the same mass as a non-diabetic individual. So here comes the importance of, so at the same LDL-C level, the number of LDL particles is increased if smaller and denser LDL particles are present. This is called as discordant high risk, and many guidelines are shifting to measuring Apob by the biochemistry department also, so as to better determine the risk of an individual. Lastly, we have lipoprotein A, which is nothing but LDL particle which has another apolipoprotein attached, that is Apo A. It is genetically determined, and about 20-25% population has higher levels, and it is again associated with increased risk. Not many drugs available, only PCSK9 inhibitors decrease this by about 30%. So to conclude, adequate control of blood sugar, blood pressure, and lifestyle measures is important, because especially triglycerides can be reduced by as much as 50% by control of diabetes and decrease in the fat intake. LDL goal, as I recommended in Indians who are at high risk for atherosclerotic cardiovascular disease, should have a goal of less than 50 in those who have established disease. Otherwise, goal should be less than 100. In statins as well as STMI and PCSK9 inhibitors can be given. However, PCSK9 inhibitors are costly. Statins are relatively cheaper because they are available in generic form. And as I said, elevated non-fasting plasma TG levels are a marker of elevated remnant cholesterol and hence increased risk. And Apob level measures the number of all atherogenic particles. And finally, lipoprotein A levels are genetically determined. Only one determination in lifetime may be enough, and statins do not do anything to lipoprotein A levels. And for patients who have achieved LDL goal, that is, for example, if subject has achieved LDL of less than 50, then you should also try to achieve non-HDL and Apob goals so as to decrease his risk to lowest possible levels. Thank you very much, sir. And the listeners.
Thank you, sir. Wonderful presentation. I am amazed like how you could master so much of biochemistry of lipoproteins in so little time. I mean, it's really wonderful for all of us biochemists to listen to that talk. Yeah, we have some questions for you, sir. So first question is, how much niacin has been effective in decreasing LDL cholesterol?
See, niacin decreases all lipoproteins. That is one thing, and it decreases about 20 to 25%. Its main use has been till now mainly to reduce triglycerides.
Yeah.
See, I'll tell you, it is important to note that there were two studies. One was AMI study, and there was another study called HPS-5 study in which niacin was tested. However, this niacin could not show decrease in cardiovascular events. So statin remain the drug of choice. Number one. Second, niacin is not presently not easily available in our country. So and for that matter, worldwide, because it has not been shown to decrease cardiovascular mortality. However, it's a good drug to decrease triglyceride by as high as 30 to 40%.
And second question is, can non-HDL cholesterol value be reported if triglyceride is above 400 milligram per deciliter?
Yes, yes, non-HDL can be used, and as a very nice question, because Friedrich's formula, which is total cholesterol minus HDL cholesterol minus triglyceride by 5, is not appropriate to be used if triglyceride levels are higher than 400. So there you are supposed to measure the LDL directly by whichever technique your local biochemistry lab is measuring it. It will give otherwise erroneous readings.
Yes. And the next question is also similar to that. So which is preferred, free-ball formula or direct measurement of LDL cholesterol? I think
So,
obviously LDL cholesterol direct would be better.
see, we have done one study with the help of Dr. Pradeep Dabla sir, and we will be publishing the results of that study. And as I said, Friedrich formula is fine as long as triglyceride levels are between 150 to 400. Otherwise, direct measurement is to be done. But many laboratories, do not do it.
Right.
That LDL measurement.
And one more question: which is the drug? Which is the best drug? Which is the drug of choice for these conditions? What is your
Drug of choice for lipoprotein induction.
I think which is you just mentioned drug of choice. So probably yes.
Yes. So as I said, statins have been shown in primary prevention setting as well as in secondary prevention setting. That is those who have disease to decrease both infarctions as well as death. So they are the drug of choice. If you are not able to achieve success with that, then you go to the other drugs.
Yeah. Thank you very much, sir. I think there are lots of questions. In the interest of time, we will cut short now. Thank you very much, sir, for joining. It was really wonderful.
It was indeed an honor, sir. Yes, sir.
Yes, sir. Thank you.
Thank
Please
you,
stay
sir.
back with us.
Yes, I'm here, sir.
Our third speaker, well, he is very familiar to biochemist, Professor Pradeep Dabla. Professor Dabla is a professor of biochemistry at GB Pant Institute of Postgraduate Medical Science in Delhi. He is a member of the IFCC Task Force for Global Lab Quality, as well as the APFCB Communications and Publications Committee, Emerging Technologies Division, and a consultant of the IFCC Task Force for Young Scientists, which probably most of us know him very well in that capacity. He is an NABL lead and technical assessor for the clinical chemistry as well as molecular testing. He is an NMC assessor, editorial board for CCLM and various other journals. With more than 20 years of clinical lab experience as a leader. And what else to say is, and I'll let him speak through the his qualities. And the topic itself is something fascinating. When I read the topic, and I was really mind-blowing, and I'm really looking forward to listening. I didn't understand anything about that, Dr. Pradeep. He's also my good friend. So Pradeep, could you just enlighten us regarding what that is, deep learning in cardiovascular diseases? Over to you, Pradeep.
Thank you, Dr. Kannan. And before I start, I must say really thanks to Professor Vipin Mehta, a very senior cardiologist from our institute, and sharing such a deep insight knowledge about the lipids and how to connect the lipids with the therapy itself. That's really fantastic, sir. I mean, having such a deep insight and knowledge about the chemistry as Dr. Kannan has also commented. Thank you very much for your presence, please.
Thank you, sir.
And Dr. Po has, of course, she has commented on very important topic when we are talking about the emergency cardiology, and she has commented on that how to have that the challenge of managing the TROP-D assay and how to assess that to BNP as well. So thank you very much. So before I start again, I would like to thanks to the webinar committee of Believers Church Medical College Hospital, and under the able leadership of my good friend Professor Dr. Kannan, and thanks to the host Professor Prakash Krishnan from the Department of Pharmacology as well. Can you please share my PPT, please? So today I'm going to share my talk and slight summary about that, how to connect the laboratory with the clinics, and a little bit about the artificial intelligence, that this technology, which is being quite very well being used into the many other areas, like we have basically we have the Alexa at home every day, but how to connect that or how to utilize that AI when we are talking about the healthcare. Next slide, please. Again, I'm glad to share the picture of my institute, one of the very reputed and the largest institute serving the healthcare services about the cardiology and the CTPS, but not less, extending to the neurosurgery and neurology and many more branches, and serving to the almost quite good chunk of patients from the North India itself. Next slide. So these are the few heads under which I'm going to share my talk and vision about that how the clinical test is and how we define the clinical test into the current scenario and where the lab stands. What is the artificial intelligence and relating to the evolving cardiac biomarkers? What are the opportunities for its improvement and a few more AI challenges? Before I start, again, the topic is quite vast enough to to justify within this much of limited time. But yes, I'll try my best to share with you. Next slide. So the patient of today's play, that AI is playing a much larger role into the decision making, whether it is regarding the treatment or further anything else. And because of today's internet and much more information and knowledge about the disease, now the current scenario is making much more greater demands onto the healthcare services. And again, emphasizing this, in today's clinical lab is becoming one of the hospital largest department and provides about more than 2/3 of their objective information and providing the vital information, because of which we are trying to shift from the strategy of one size fit all medicine to the precision medicine, where we are trying to on the basis of the genetics and few more and very specialized testing, we are trying to concise the treatment to the personalized medicine itself. Next. So before again I start, that Dr. Poe has also mentioned a lot about the cardiac biomarkers. That the cardiac biomarkers that refers to the protein molecules which are released into the bloodstream. Of course, we as in doctors and the part of lab we all know, and that is again due to the heart-related damage or stress, and again because of that, the market or because of the disease itself, the global cardiac biomarkers testing market was valued about 9,700 million. That's quite huge in 2020, and it's projected to reach about 28,000 million by 2030. So you can see that how much the demand in the market is about the cardiac biomarkers itself, and with the growth rate about at 10.9% from 2021 to 2030 itself. So again, that significant growth in owing to this, that's the rise in need of the cardiac biomarkers is again because of the high prevalence of the cardiovascular disease, as Dr. Vimal has emphasized a lot. And again, now we are into the COVID-19 era, again, that cardiovascular disease is becoming a highlight of today's time. And the rising population of the older age, the rising cardiac disease are the growth drivers of this market. Again, Dr. Poe has also emphasized that when we are talking about the emergency itself, the cardiac emergency, so there are the two cardinal markers, which are the evidence-based and which are guideline endorsed and widely clinically applied markers. So one is the cardiac troponins and the another is natriuretic peptides. So when we're talking about the TROP-T, so it means that we are talking about the immediate the management strategies when we are talking about the emergency settings, and when we are talking about the natriuretic peptides that are we are trying to improve the diagnostic certainly and to provide the early risk stratification in case of the acute heart failure itself, and also as a part of a chronic heart disease. Next slide. So, talking more about the cardiac biomarkers now, where the lab stands when we are talking about the cardiac biomarkers, where the laboratories are required. So, again, I'm stressing on to the emergency setting. So, approximately 2% of patients with acute MI have their diagnosis missed into the emergency department. Now, there are the several reasons, of course, for this. So, I'm mentioning the few. So one is the inappropriate discharge of the acute MI patients, because the core problem is the admission of patients with a low probability of the acute coronary syndrome, which we may miss the cases requiring the urgent help, or we may miss the patients which could have the ACS with the atypical symptoms. So that means the diagnostic protocol is very important. The testing protocol is very important in that case. Now, the second is that it means that laboratory should work together with the emergency physicians or the cardiologist or the clinicians or the primary care physician into the decision making and to the strategy formation. Now, again, if I'm talking about the one more thing is the chest pain centers, what we call as the rapid AMI rule-out protocols, which are very essential for the early MI cases, and that to be powered by the electrocardiographic testing and the time blood collection for the measurement of the cardiac biomarkers. Again, more important is about the quality assurance, which can only be benefited and can be stressed with the help of the laboratory people while making the testing protocols. So, next slide. So, it means that what is the new into that? It means that the rule out acute AMI process, where we are talking about the cardiac troponin, it is the sole recommended biomarker using the 99th percentile cutoff point with the 2 lab results drawn at the time of 0 and 3 to 6 are that Dr. Poe has already explained what. So, again, the important things when we are talking about the image settings, the rapid cardiac biomarker testing that may lead to the early detection and use of the appropriate therapy. So, is it true that getting that lab test at the earliest or the first test result at the earliest can make the change into the diagnosis or to the prognosis of the patient? But when you're going into the details, it is quite a complicated phenomenon. When we are talking about the say suppose the turnaround time. So it is complicated for the laboratories to consistently, delivering that 90% of the results within 30 minutes, or maybe the 100% results with 30 minutes. So it means that the result of the cardiac biomarkers testing are not used to guide the thrombolytic therapy, as stated earlier, and also that as per the literature available, there is no clear evidence that the availability of rapid biomarker results can lead to the better patient outcome. So it means that serial sampling or the sampling from 0 to 3 to 6 hours is important, where you can see the delta check, that is the change of the cardiac troponin markers concentration. So when we are talking about delta check, it means that the cardiac troponin measurement to a single diagnostic threshold is not always sufficient to rapidly and accurately diagnose the AMI. So it means that we need to observe a rise and a fall into the cardiac troponin concentration. That means the change of concentration within a particular algorithm or the R's being defined. So that we call as the optimal medical decision points. And it is just cannot be based on to the positive or negative results, but what we need is the quantitative results. And but again, one more important thing that as Dr. Poe has defined that being this 99th percentile is being defined by the work of the both ACC and ICC. Now, while we're defining the clinical relevant threshold values, it is really complicated, and the international guidelines for the diagnosing acute MI, where we are trying to endorse implementing the 99th percentile of a healthy population as the upper reference range, or the upper reference limit, but there are limited recommendations are present that how to select that the healthy reference population. So the guidelines are also calling for the detection of change in troponin concentration over the time. That is, we call it the delta change, but they do not define the specific strategies or the rules for detecting those significant delta. So that the committee of the ACC and IFCC has given their expert opinion into their recommendation in 2018, where they recommends that the high sensitivity methods for the cardiac troponin I and cardiac troponin T assay should satisfy the two fundamental criteria. First, as I defined, the 99th percentile of that healthy population should be measured. Secondly, the high sensitivity methods should also measure the cardiac troponin concentration above the level of detection, and that method should be able to detect that rise in at least 50% of the healthy subjects that enrolled in large population, including more than 300 men and 300 women. So, as I'm trying to explain, it is becoming more and more, the complicated. It is not as it is, it is not a one-liner. So it is a complicated in practice, but as it says in words. Again, when we want to have look into the emergency settings, the point of care testing devices are very important, because they can lead to the expedite the patient discharge and the reduction into the turnaround time. Next slide. So it means that when we are talking about the emergency setting itself, because I'm trying to concentrate there only. So it means that monitoring and measurements and the role of lab personnel is very, very important, whether it is related to the selection of devices, whether it is related to education training, the maintenance and the qualitative assurance, registry of data, etc. The verification or the validation or the proficiency programs of that equipments or the testing itself, the compliance of the regulatory requirements, the reimbursement, the maintaining of the or the managing those reimbursement for the testing protocol is quite highly important when we are talking about the role of the lab person. For example, if I say in hospitals of the US, say suppose if they say that the comments they comment that it is not necessary to use troponin in addition to the creatine kinase, which includes the CKMB. So, but it means that the hospitals which are using both the strategy of utilizing the cardiac troponin T and CKMB, they may not get the reimbursement for the full cardiac biomarker testing, but for the cardiac troponin T only. So the guidelines are very important, and that need to be to be made with the that interface linking of both the labs and as well as the clinics. Next slide. So coming to the important part, that is the artificial intelligence, giving the importance about the emergency settings and the role of the lab personnel. So the artificial intelligence, it describes a range of techniques that allows the computer to perform a task typically thought to require the human reasoning and the problem solving skills. And they are based on to the predetermined rules and search algorithms, which we call as the search of the data, and or that can also be we also say that the pattern recognizing the machine learning models, and thus processing the large amount of data and recognizing the patterns in data, that we call as the IoT, that is the Internet of Things. As you can see to the pictures, where the blue dots are the prerequisites or the information we are trying to collect and to make together, like we have a process of thinking into our neurons, and we are trying to connect and we are trying to bring all the heads together to bring the one information or the outcome of all those inputs as an outcome, which can be for example, which can be a comment onto the testing protocol, which can be a comment that how that treatment was effective onto that patient for maintaining that levels of the lipids. For example, in this, I have utilized the size of a cancer, size of a cell. So if we are talking about the morphology, height, stiffness, thickness, and we are taking as a prerequisites, and we are taking together all the information, that is going to give us the output of the healthy or the cancerous cells as per the input, as per the size or the stiffness, thickness of that particular cell. So this is, we call as a little bit an idea about the artificial intelligence or the machine learning. Now, that the artificial neural networks are a common type of machine learning, which is inspired by the way in that how our animal brain works, and it is a multi-layer of the interconnected units like our neurons work in our brain, and that process the information by responding to the external inputs as the blue dots, and thus relying of information between the units require the multiple passes at the data to find connections and drive the meaningful mathematical computational model that we call as the machine learning. Next. So that artificial intelligence, that evolving.
Dr. We are running short of time. So can you?
Right. So that AI is, that led to the significant paradigm shift into the medical knowledge due to the ability to support decision making and improve the diagnostic and prognostic information. And the machine learning, as I've already explained, it is a subset of AI algorithms related to the ability of learn from a large amount of data. Next slide. And the new cardiac biomarkers must provide the information in readily available and affordable fashion, and that is available with relate to the current standard practice, and it must meet the high standard of the precision and the accuracy, and they should be able to meet the unmet needs in provision of the valid surrogate endpoints or the therapeutic targets, which are relating to the various axes of the cardiac the cardiac biomarkers, maybe the inflammation, maybe the oxidative stress, maybe the renal function, or maybe the cardiomyocyte injury itself. And Omics is again a new technology which is enabling extensive screening of markers in any given CAD, whether it is related to proteomics or metabolomics. Next slide. So it means that that the models can be developed, as I said earlier, to predict the various outcomes. For example, predicting the drug concentration using all these features, as I said earlier, or predicting the compliance of that the patient group, or also to comment onto the treatment failure or success with respect to the outcome defined, the ranking of features or the better compliance, etc. So this is just the slide is showing our work of our MHBLM, that is the Mobile Health Engineering, the Committee of the Emerging Technologies Division of the IFCC, where we have published an opinion paper with the reputed journal of IFCC in 2021, where we try to emphasize that how these AI techniques has proven to be powerful tools in fighting against the COVID-19 pandemic. Next slide. Nonetheless, we extended further at the team ICC MHBLM with the team India, with also and with the help of Vibal sir, we were able to gain the design patent with the Australian government titled the Developing Early Risk Estimation Machine Learning Model into the Early Onset CAD Patients for the Prediction and Outcomes, where we were able to build the statistical model by performing the machine learning analysis on the set of data of the biochemical markers, imaging, and the non-invasive procedures, as well as the angiography for the early risk stratification and developing the precision cardiology severity score for those patients. Next slide. Again, this is about that how the further papers are published by us and the other authors and the scientists which are working to bring that AI and connect with the cardiovascular diseases. Next slide. So again, this is a very, very important and very close slide which is close to my heart, where I always, try to give and try to, emphasize the interface linking between labs and the clinics. And it is of fundamental importance to ensure that the patient is giving the high quality care. We need to give the high quality care to the patient by adding value to our lab test, where the test should be clinically valid. They provide the highly accurate diagnostic information. They should be clinically effective and should be cost effective, where they can contribute to reduce the healthcare cost, and where we also, with that all that we need to address the lack of communication between the clinician and the laboratory services. Next slide. So as Dr. Vimal was so fantastic, giving the basic information about the lipids and its connect with the therapeutic itself. So if you go to the literature, you will find that the doctors are needing the most help while they are where they want to make a diagnostic. So our motto should not be like, as you can see to the slide, we are giving a menu to a patient and we are asking them to ask for which test you want. But our motto should be that we need to be help our clinicians that which test is specifically needed to make that that outcome better. Next slide. Again, the few more the importance of that, how the evidence-based lab medicine and being supported by the various organizations like the UK NICE and the CPOE and NOCLUS, where they giving the algorithms, and they're giving the help to investigate the appropriate test selection and the interpretation and the medical decision itself. Next slide. But again, very important from my side is that, are we teaching our students to become giving an importance of a laboratory, or we are giving them just straight away that, yes, you just go and treat the patient. But if you see that, what are the future doctors learning today about the laboratory test? And that has been made visible and has been emphasized when that's curriculum of the MCI being changed in 2019. So it's just a joke, but no one does a heart biopsy to diagnose a heart attack. But it means that we need to have a emphasis of the teaching of laboratory medicine into our medical schools. We need to help them to have a test selection and to the result interpretation. Next slide. This is again being helped by the MCI to have that early clinical exposure and using the cases and teaching into the class and into the clinics and to the laboratory itself, and with the help of the paper cases and photographs, and so much of change being emphasized by the MCI now is the NMC for making this the teaching of the medical classes and the MBBS teaching more useful, and to connect both the labs and the clinics together. Next slide. It means that we need to have emphasis onto a laboratory or to a department with the sharing of information. Next slide. Last slide is this is my last slide, just to how this AI, it is easy to say, but it is difficult to address. Why? Because yes, we have a data, we can take out the data, we can have a comment onto the few more outcomes, but yes, the privacy in that case is very important, and it is having so much of talk that is going to impact onto the doctor-patient relationship itself, and how much we are having the accuracy, or we have how much the standards we are developed, where we can attach with the accuracy and the respective standards. Now the medical legal is very important area to be taken care of. It means that the various nations and the responsible bodies should work together to develop the standards which are still lacking to guide those AI work into the various fields. And in that field, that FDA, where they have developed their policy for device software functions and mobile medical application guidance, was being issued in 13 and being updated in 15 and 19. So I again say that we still have a lack of standards, and we still have a lack of working together. That is most important when we are shifting to the AI, when we are going for the real patient care, taking help of an AI. Next slide. Lastly, again, I'm emphasizing onto the interface linking where there's a need for the growing cooperation between the patients and between the labs and to the clinics to provide the guidance onto the test selection and to the interpretation of the analytical test results. Next slide. Thank you very much for your kind patience and for your kind listening to me and giving an opportunity to present my talk. Thank you very much.
Thank you, Dr. Dabla. Thank you, Dr. Pradeep Dabla. And it's your passion really shows, and I personally know your passion for this topic. And I'm sure with more work from you, it will get more recognition in the days ahead. Really, artificial intelligence is the future of laboratory medicine, maybe medicine itself. So, as you, some of you might be knowing that artificial intelligence is going more and more into our lives as well. I'm sorry, due to the lack of time, we won't be able to entertain questions. And I'm sure there are lots of questions which you have really inspired lots of thoughts into all of us, including myself. And
Thank you
there
very
are
much.
lots of questions maybe you can address in the coming SCBI conferences also. And I hope I can invite you for a talk over here as well, where you can physically come and share with our lab personnel. They would be really delighted to have you here. So thank you very much, all speakers. And I would like to thank all the delegates for participating. All registered participants will be getting the certificates. Unfortunately, we can't honor the speakers now physically over here because it's a webinar, but we'll be sending you certificates of appreciation for spending your time with us and spending your efforts and time with us. And I hope we will be able to invite you over here to our institute as well. It's a wonderful institute, and thank you very much all for participating. And I really enjoyed, and I hope you also had a good time participating in this webinar. Over to the host, Dr. Prakash. Thank you very much.
Thank you, Dr. Kannan, sir. I thank all the participants who are logged in today for the webinar, all the three speakers, and our moderator, Kannan, sir. Hope to meet you all next Wednesday for our next webinar. Thank you all for logging. Have a nice day.
Thanks a lot again to all of you for inviting and
So thank you all.
for the patients listening. Thank you very much, dear all.
Thank you, Dr. Blabla. And Sue has already left, I think. So it must be late in Singapore.
Keep it. Thank you. Take care.
I'm
Thank
still
you,
here.
Dr.
Thank
Bo,
you very
for doing
much.
that.
Oh, there. Okay.
Bye-bye.
Thanks.
Thank you. Bye.
Thank you, Vimal sir. Thank you so much.
Thank you, Dr. Pradeep, for this opportunity. Thank you so
Thank
much.
you, sir. Thanks so much.
Always grateful for your kind patronage.
Forward to believers soon.
Sorry?
I'll be inviting you. You hope you can make
Oh.
it forward here soon.
My pleasure, sir. Thank you very much. It's been always pleasure meeting such a good friend.
Okay, thank you. Bye. See you.
Thank you, sir. Thank you so much.
Thank you.
Take care. Bye-bye.